Hello friends, I'm Dr. Ram. Today I will discuss the introduction of benign prostatic hyperplasia and what's its treatment. This is a picture of enlarged prostate. Here you can see another picture in which there is an enlarged prostate. Benign prostatic hyperplasia is a common disorder that increases in frequency progressively with age in men older than 50 years and is hormonally dependent on testosterone and dihydrotestosterone production. Microscopic appearance of BPH is present in 50% of men by age 60. Microscopic appearance of BPH is present in 90% of men by age 85. It is a non-cancerous enlargement of the epithelial and fibromuscular components of the prostate gland. The widening dysfunction that results from prostate gland enlargement and bladder outlet obstruction is termed lower urinary tract symptoms. It has also been commonly referred to as prostatism, although this term has decreased in popularity. These entities overlap. Not all men with BPH have lower urinary tract symptoms, and likewise not all men with lower urinary tract symptoms have BPH. Approximately half of men diagnosed with histopathologic BPH demonstrate moderate to severe lower urinary tract symptoms. Pathophysiology of benign prostatic hyperplasia. Lower urinary tract symptoms and signs of benign prostatic hyperplasia are due to static dynamic detrusor factors. The static factor refers to anatomic obstruction of the bladder neck caused by an enlarged prostate gland. As the gland goes around the urethra, the prostate occludes the urethral lumen. The dynamic factor refers to excessive stimulation alpha-1 adrenergic receptors in the smooth muscle of the prostate, urethra, and bladder neck, which results in smooth muscle contraction. This reduces the caliber of the urethral lumen. The detrusor factor refers to bladder detrusor muscle hypertrophy in response to prolonged bladder outlet obstruction. Hypertrophy helps the bladder to generate high pressure to overcome bladder outlet obstruction and empty urine from the bladder. The hypertrophic detrusor muscle becomes irritable, contracting abnormally in response to small amounts of urine in the bladder. If obstruction is not treated, the bladder muscle will decompensate and be unable to empty completely. The post-white residual urine volume will increase. Prostate enlargement is influenced by a combination of androgens, growth factors, estrogen, and epithelial stromal interaction. Dihydrotestosterone in the prostate gland type 2 5-alpha reductase metabolizes circulating testosterone into dihydrotestosterone, which works locally, not systematically. Dihydrotestosterone binds to androgen receptors in the cell nuclei, potentially resulting in benign prostatic hyperplasia. Androgen stimulates epithelial but not stromal tissue hyperplasia. In an enlarged gland, the epithelial stromal tissue ratio is 1:5. Hence, androgen antagonism does not induce a complete reduction in prostate size to normal. This explains one of the limitations of the clinical effects of 5-alpha reductase inhibitors. Stromal tissue is the primary locus of alpha-1 adrenergic receptors in the prostate, and estimated 98% of alpha-1 adrenergic receptors in the prostate are found in prostatic stromal tissue. Of the alpha-1 receptors found in the prostate, 70% of them are of the alpha-1A subtype and remainder are of the alpha-1B and alpha-1D subtypes. This explains why alpha-adrenergic antagonists are effective for managing symptoms of benign prostatic hyperplasia. Clinical picture of benign prostatic hyperplasia. Causes of male lower urinary tract symptoms: benign prostatic enlargement, secondary to benign prostatic hyperplasia, urinary tract infection, prostatitis or active bladder, neurogenic bladder dysfunction, urethral structure, bladder neck contracture, phimosis, urinary tract stones, bladder tumor, advanced prostate cancer, foreign body in the bladder. Medications, illicit drugs, and dietary factors include caffeine, alcohol, ketamine, and decongestants, and at-large diabetes mellitus. Lower urinary tract symptoms can be categorized as symptoms related to storage, widening, or post-maturation. Storage symptoms. Storage symptoms experienced during the bladder filling and storage phase of maturation include urgency, a sudden compelling desire to pass urine that is difficult to defer. Daytime frequency, a patient's perception that he whites too often by day. Nocturia, the need to work at the night one or more times to white. Urge incontinence, involuntary leakage accompanied by or immediately preceded by urgency. Whiting symptoms. Whiting symptoms are those experienced at the time of urine flow and include slow stream, the individual's perception of reduced urine flow usually compared to previous performance and sometimes compared to observations of other men. Splitting of spring of the urine stream may be reported. Intermittent stream or intermittency urine flow that stops and starts on one or more occasions during maturation. Hesitancy, difficult in initiating maturation, resulting in delay in the onset of whiting after the individual is ready to pass urine, straining to white, and abdominal muscular efforts used to initiate, maintain, or improve the urinary stream. Terminal dribble, prolongation of the final part of the maturation when flow has slowed to a trickle dribble, dysuria, pain, burning sensation, or general discomfort at the time of passing urine. Post-maturation symptoms. Post-maturation symptoms include a sensation of incomplete emptying after passing urine. Post-maturation dribble, the involuntary loss of urine shortly following urination, usually after leaving the toilet. The term lower urinary tract symptoms or LUTS is non-specific. Lower urinary tract symptoms is also associated with severe sleep disturbance, increased depressive symptoms, and decreased ability to perform activities of daily living. Diagnosis of benign prostatic hyperplasia. History, onset and duration of symptoms, severity of symptoms, and how they are affecting quality of life. General health issues including sexual history, history of urethral trauma, urethritis, or urethral inflammation that could lead to urethral stricture, fitness for any possible surgical interventions, medications, previously attempted treatment, family history of BPH cancer prostate. The severity of BPH can be determined with the International Prostate Symptoms Score, American Urological Association Symptom Index, plus a disease-specific quality of life question. Questions on the AUA-SI for BPH concern the following: incomplete emptying, frequency, intermittency, urgency, weak stream, straining, nocturia. Score 0 to 7, mild symptoms. Score 8 to 19, moderate symptoms. Score 20 to 35, severe symptoms. Physical examination, suprapubic area for signs of bladder distension, dullness, tenderness, the digital rectal examination, neurological examination for sensory and motor deficits, decreased anal sphincter tone, or the lack of a bulbo-cavernous muscle reflex may indicate an underlying neurological disorder. Digital rectal examination, prostate size, symmetry, and contour can be assessed. Nodules can be evaluated. Nodularity more with benign BPH and areas suggestive of malignancy can be detected. The normal prostate volume in a young man is approximately 20 grams. Laboratory studies for benign prostatic hyperplasia are urinalysis, urine culture, prostate-specific antigen, electrolytes, blood urea nitrogen, and creatinine. Ultrasonography determine bladder and prostate size and the degree of hydronephrosis, if any, in patients with urinary retention or signs of renal insufficiency. Generally, they are not indicated for the initial evaluation of uncomplicated lower urinary tract symptoms. Abdominal transrectal ultrasonography of the prostate is recommended in selected patients to determine the dimensions and volume of the prostate gland. In patients with elevated PSA levels, trust-guided biopsy may be indicated. Flow rate. Routine non-invasive uroflowmetry. For the results of uroflowmetry to be valid, the patient needs to write more than 150 ml of urine, useful in the initial assessment and to help determine the patient's response to treatment. A low urine flow rate may indicate nutritional impairment or BOO. A Qmax of less than 10 ml per second is highly suggestive of BOO. PV or urine volume, used to gauge the severity of bladder decompensation. It can be obtained invasively with by-in-out catheterization or non-invasively with a transabdominal ultrasonic scanner. Urodynamic studies. to differentiate men with a low urine flow rate caused by obstruction or impaired bladder muscle contraction. Pressure flow studies also assess for involuntary bladder muscle contractions, detrusal or activity during the bladder filling phase before voiding while considering surgery. Cystoscopy indications: patients scheduled for invasive treatment, suspected foreign body, suspected malignancy, patient with a history of sexually transmitted disease, prolonged catheterization, trauma. Cystological examination of the urine may be considered in patients with predominantly irritating voiding symptoms. Symptoms often attributed to benign prostatic hyperplasia can be caused by any of the following conditions: cystitis, prostatitis, prostatodynia, prostatic abscess or active bladder, carcinoma of the bladder, foreign bodies in the bladder, stones or retained stents, urethral structure due to trauma or sexually transmitted disease, prostate cancer, neurogenic bladder, pelvic floor dysfunction. Complications of benign prostatic hyperplasia. Complications of untreated benign prostatic hyperplasia: urinary retention, urinary incontinence, renal insufficiency, recurrent urinary tract infections, urosepsis, gross hematuria, bladder calculi, bladder diverticula. Treatment objective of benign prostatic hyperplasia: to identify and correct associated complications which may be life-threatening, to relieve the obstruction of urinary flow. General measures for benign prostatic hyperplasia: massage, stress management can all be used as adjuncts to tension headaches. Suprapubic cystotomy: if urethral catheterization fails, then refer. Suprapubic needle puncture and aspiration, drainage of urine to partially decompress the bladder and relieve pain when suprapubic cystotomy is delayed. For definitive treatment, prostatectomy. Pharmacological treatment of benign prostatic hyperplasia: tablet terazosin oral 2 to 10 mg at night. Initial start dose of 1 mg at night. This may be doubled at weekly intervals according to response up to a maximum of 10 mg, or tablet tamsuline oral 400 microgram once daily, or tablet alfuzosin SR oral 10 mg daily plus tablet finasteride oral 5 mg daily. These medications may have side effects such as lowering of blood pressure and dizziness. They are therefore recommended to be taken at night.